Assalamu alaikum, everyone. Assalamu alaikum. At Shaukat Khanum, my colleague over here is Dr. Irfan Yusuf, consultant neurosurgeon. I think before further ado, we should kick off the session. So I would invite our first speaker, who is Dr. Syed Fatma Gilani from Shaukat Khanum, Peshawar. And she's going to talk about accessing the necessity and utilization of post-operative intensive care in hepatopancreatico-biliary surgeries. Is it time to change our practice? So,
Good morning, everybody. Thank you for being here. I'm Dr. Fatma Gilani, and I'm here to present a study conducted under the supervision of Dr. Syed Irfan Kabir, which was centered to reassess the necessity and utilization of post-operative intensive care in hepatopancreaticobiliary surgeries, HPB surgeries. To begin with, let's talk about the pertinent fact that HPB surgeries are known for their complexity, with a substantial morbidity of 28.4% and mortality of 2.7%. Therefore, there is a tradition of routine ICU or HDU admissions post-surgery. However, not all patients may require ICU-level intervention. Our study aims to reevaluate this current ICU admission practices and to explore the potential for more selective ICU admissions based on actual intervention needs and individual risk factors. So now the question is, why is there a need for this reassessment? The answer is, ICU admissions are costly and may be unnecessary for all patients, providing a very financial stress on hospital, and not only financial stress, but also a stretch on the staff and space, resulting in overutilization of resources without affecting patient outcomes. And also it decreases the access of ICU to patients who actually need ICU care. There were three main objectives which were defined before the study. The first one was to assess the need for ICU interventions and identify the patients who are actually needing the ICU interventions and underwent ICU interventions after post-hepatopancreaticobiliary surgeries. The second objective was to identify predictors of ICU admission and readmission. And the third objective was to develop a criteria for selective ICU admissions. It was a retrospective cohort of 254 elective HPV surgeries between April 2021 and April 2024. Data was retrieved from hospital's electronic database, and statistical analysis was done using SPSS to assess patterns of intervention use in the ICU. We defined an inclusion and exclusion criteria. Inclusion criteria were all the elective HPB cases during that time frame. And exclusion criteria were emergency cases, under 18 cases, HPB surgeries as part of other specialty procedures, and incomplete data. So to identify the outcomes of ICU interventions based on different key factors, we identified certain key variables such as demographics, which were age, gender, comorbidities such as diabetes, cardiovascular diseases, hypertension, etc. Surgical factors were looked into such as BMI, ASA score, extended surgery time, especially greater than 6 hours, intraoperative transfusion or blood loss, intraoperative inotropic support, and perioperative morbidity. ICU interventions were identified such as mechanical ventilation, inotropes, invasive monitoring, renal replacement therapy, blood product transfusion, etc. Moving towards the results, about 254 patients were analyzed. Out of those 254 patients, 165 were admitted to ICU. Out of those 165 number of patients, 137 number of patients only underwent observational care, and a significant number of only 28 patients over a period of 2021 to 2024 underwent significant interventions in ICU. Patients who went to ICU underwent lap Whipples, about 43% of them. After that, liver surgeries, and then open Whipples, pancreatic surgeries, etc. 46.7% of the patients were female, and 53.3% of the patients were male. Out of those patients, in only 39.4% of the patients, there were significant comorbidities, with diabetes mellitus being the most prevalent one. About 4.2% of the patients had received inotropes intraoperatively. About 22.4% of the patients received intraoperative blood transfusion. Perioperative morbidity was observed in about 9.1% of the patients. Perioperative morbidity such as hepatic vein bleed, portal vein bleed, state of shock, etc. The mean age was identified as 52.9, BMI as 23.96, mean stay in ICU was 32.67 hours. Age range and BMI range was categorized based on literature review. About 4.8% of the patients were readmitted. Rest 95.2% of the patients were not readmitted after stepping down from ICU. About 98.8% of the patients were discharged safely to home. In the total cohort, only about 17% of the patients received interventions. And in about 83% of the patients, there was only observational care that was identified. And out of that observational care, only 71.5% of the patients received standard monitoring only. Analysis was done using chi-square test, one-way analysis of variance, and logistic regressional analysis. We identified that ASA score and BMI had a significant association with intervention in ICU with a p-value of 0.001 and a p-value of less than 0.001 respectively. Presence of comorbidities, intraoperative transfusions, intraoperative inotropic support, and perioperative morbidity also had a very significant association with interventions in ICU with a p-value of less than 0.001, odds ratio of 8, 5, 30, and 14.5 respectively. We observed that gender, type of surgery, and duration of surgery, and intraoperative blood loss did not have a very significant impact on ICU interventions. Logistic regression analysis was run, and we found out that presence of comorbidities, intraoperative use of inotropes, perioperative morbidity, and blood transfusion had a very significant association with interventions in ICU. We also found out that each unit increase in ASA score and each additional year of age increased the odd of ICU interventions by 14.9% and 13.8% respectively. One-way variance analysis was run on categorized patients, and that showed that patients who were aged greater than 60 years had greater chances of interventions in ICU. Similarly, on two extremes of BMI, less than or equals to 18 and greater than or equals to 29 received more interventions in ICU. Then we observed that ASA score of greater than or equals to 3 received more interventions in ICU. Positive correlation was found between blood loss and length of ICU HDU stay with a tool-tail significance of 0.006. And similarly, positive correlation was found between perioperative morbidity and length of ICU HDU stay. So we conclude that a substantial number of ICU admitted patients after HBB surgeries did not receive any active interventions, indicating a potential to redefine ICU admission criteria, prioritizing patients more likely to need critical care. Therefore, implementing selective ICU admission protocols could optimize resources and patient outcomes. So we suggested a criteria of a patient who were aged greater than or equals to 60 years with BMI less than or equals to 18 and greater than or equals to 29, patients who had significant perioperative morbidity, intraoperative transfusions or inotropic support with significant comorbidities, and patients with ASA score greater than or equals to 3, and patients who underwent greater than 6 hours duration of surgery should be admitted to ICU. All other patients were considered lower risks and can be managed in low acuity settings. There were certain limitations to this study. This was a single center study, and a small sample size was there. Therefore, association with readmission rates could not be established. These are the references. Thank you so much for your attention.
An excellent presentation.
Thank you.
So have you put this in practice now?
This was a pilot study.
Yeah.
We are moving towards a prospective experimental study based on this study.
Okay.
So we'll put into practice by defining cohorts. Yes.
Hopefully, and then we'll know
For sure.
for sure how good
Yes.
it is. Yeah, but
Yes.
certainly, with limited resources and everything, and the cost of medicine these days, I think it's a very good way of moving forward and utilizing your resources to the fullest extent. Thank you.
Thank you.
Irfan.
Thank you for your excellent study. I think, as you mentioned, you already have some patients who are not admitted to ICU.
Yes.
So there is already, um, a process that you use to select these patients.
Yes.
And certainly you're looking at patients who would, according to your current practice, go to ICU and then come back without significant interventions. And that was a very good idea to look at. So in terms of the criteria that you're proposing to go by and limit the admissions to ICU, uh, are you going to construct a scoring system to use, each variable like age? You say, what score would you give it in terms of its importance or significance in terms of the patient outcomes? Can you look into that to
For-
devise a scoring system?
For now, what we're planning to do is put this criteria into practice for an experimental cohort study. When we get the results from that, we will make a scoring system,
Okay,
which would be helpful and with a greater sample size.
thank you. So our next speaker is Dr. Nurul Ain from Shaukat Khanum Memorial Cancer Hospital and Research Center, Peshawar, and she's going to talk on the factors leading to adjuvant chemotherapy delay and omissions post pancreatic cancer resection. Dr. Nurul Ain.
Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Nurlan, working as a surgical resident in Shaukat Khanum Hospital, Peshawar. As you can see by the title, the topic is factors leading to adjuvant chemotherapy delay and omission post-pancreatic cancer resection. Before we go on a real topic, let's have a little bit background on pancreatic cancer. So pancreatic cancer is a highly aggressive neoplasm and expected to be the second leading cause of cancer-related mortality. Mortality closely parallels incidence. The surgical procedure performed for pancreatic cancer is pancreaticoduodenectomy, commonly known as the Whipple's procedure, both performed through both open and laparoscopic approaches. Surgery does offer a chance of cure, but 5-year survival is still less than 40% even after surgery. Local and systemic recurrences occur. After resection, adjuvant chemotherapy can significantly improve disease-free and overall outcomes. For this purpose, different trials have been done worldwide. We will go quickly through these 3 trials. So we have the CONCO 001 trial, in which the effects of gemcitabine was investigated. A 6-month treatment showed 24% improvement in overall survival. Another trial named ASPECT 3 trial, following the CONCO trial, came, in which the effects of fluorouracil and folinic acid was compared with the previously used gemcitabine in the CONCO 001 trial. A median survival of 23 months was found for patients which were treated with fluorouracil and folinic acid. Another single institution experience done at the Johns Hopkins showed a median survival of 19.5 months as compared to the 13.5 month survival without the therapy. So these trials prove that adjuvant chemotherapy is a standard of care and one of the crucial part of the multimodal treatment of pancreatic cancer. The timeline to receive adjuvant chemotherapy is between 6 to 12 weeks. It can be as early as 6 and can be delayed till 12 weeks. After 12, it can be given, but does not that have much significance. Studies done worldwide have shown that a patient undergoing pancreatic cancer do not receive this therapy because they have poor general health conditions or they have post-op complications, which lead to decreased survivals and mortality. So the objective of our study is to assess which factors are associated with delay in receiving chemotherapy, not receiving, and then if they are receiving it, are they completing the doses? For this purpose, we performed a retrospective cohort study. We randomized patients from our hospital database between the duration May 2021 and September 2024. We included all those patients who presented to the HPB clinic having pancreatic cancer and underwent pancreaticoduodenectomy. We excluded the patients who had underwent emergency cases and other than pancreatic cancers. We took a sample size of 80, in which there were 44 males and 36 females. The procedure mostly performed approaches were open and laparoscopic. So 62 patients underwent open and 18 went under laparoscopic. In the chemotherapy decision outcomes, 69% of our patients received the chemotherapy. 6% refused. I will discuss further that why did they refuse. 20% were not offered because it was not indicated in them. They either had benign disease or neuroendocrine grade 1 tumor, grade 2 tumor, pseudopapillary tumor. 5% patients missed their window, which was between 6 to 12 weeks. The regimens offered, these were the regimens which were offered in our patients. After the PRODIGE 24 trial, modified FOLFIRINOX is the standard of care, but in our setup, it was GemCap mostly, followed by CAPOX. So we considered those patients who omitted therapy in the missed window and refused part. 5 patients missed their window because they had prolonged hospital delay due to surgical complications. 4 patients refused the therapy. Again, they had surgical complications. 1 had other reason. 2 patients had delay in receiving after 12 weeks, and they both had prolonged hospital stay due to surgical complications. Those who had interruption in the chemotherapy, out of 3 had surgical complications and 8 had intolerance to the treatment. So the factors which we assessed were age, BMI, comorbs, the type of procedure, whether they received new adjuvant or not, pre-op ASA score, and complications. We graded the complications according to the Claby and Dindo classification. 36% patient had grade 1 to 3 complications, 3.4% had grade 4, and 50% had no complications. The complications mostly we observed were surgical site infections, deep organ infections, acute pancreatitis, delayed gastric emptying, and post-op abdominal collections leading to reloculoprotomies. So we analyzed our data by SPSS 22 and performed a correlation. We also ran a regression analysis. So the only correlation which we found was between not receiving chemotherapy. It was mostly age. Comorbs, if patient had comorb, there's a high likely chance of not receiving the chemotherapy. High ASA score pre-op. We ran a regression analysis which showed a positive relation. The positive slope shows that the more we increase the age, comorbs, the more there are comorbs, more ASA score pre-op, there's a high likely chance that the patient can omit the chemotherapy. So in our limited number of patients, the only factors which we found were age, comorbs, high ASA score, and which leading to not receiving the chemotherapy. Rest we could not find any. So in our limitations, it was a retrospective study, and due to small sample size, we could not find a correlation between post-op complications and not receiving the treatment or delay in receiving, like the other studies showed worldwide that post-op complications were a major factor in not receiving the treatment. Thank you.
Thank you, Dr. Nurulan. Excellent presentation. You know, your study kind of brings home a message that we received in the earlier presentation. You're reaching the same conclusion. Even chemotherapy delays are dependent on age, comorbs, and ASA scoring. Am I right? So, you know, you're touching a different aspect of the same treatment plan for pancreatic cancer. On one end, we feel that these comorbs, these parameters which you just mentioned, age, comorbs, and ASA, were also affecting our decision in terms of getting patients into ICU. So certainly very important factors that we're looking in. So in terms of the delay, did you find out how long was the delay? Was it just a few days, few weeks?
Yes, weeks.
In patients who didn't get chemo, and did it kind of reflect in their eventual tumor control? Did it go that far, or we are just looking at the time span or the delay that happened? Did we look at the endpoints in terms of outcome?
No, we did not look at the outcomes. We just the delay.
Okay, but we have studies that suggest that if we delay treatment, it will adversely affect the outcome
Yes.
and tumor control.
Yes.
Okay. And do you find any religious cultural fractures, family interventions, that could affect patients going through chemo?
No.
Okay. Thank you very much.
Just one question, please. Further to Dr. Irfan's question, do you think that based on this, there will be a change in how you counsel patients?
Yes.
That it could eventually affect their outcome, their oncological outcome?
Yes.
Have faith from the counseling patients.
Yes.
Thank you so much. So moving on, we'll have our third presentation, and it's by Dr. Sumbul Naz from County Durham in Darlington, NHS Foundation Trust, Darlington, UK. And it's regarding scout-guided excision of non-palpable breast lesions, a review of procedural success and challenges. Is this
Good morning, everyone. I'll be sharing my screen shortly.
online?
Um, Sorry, there is some problem with my screen share.
Okay, take your time.
Can you see my screen now?
Yes. So, you have 2 minutes extra. Our timer shows 8 minutes. I think, is it possible to reset the timer up there?
Am I all right to start?
Yeah, go ahead.
Okay. Good morning, everyone. My name is Dr. Sumbul Naz, and I'm currently working in County Durham and Darlington NHS Foundation Trust as a specialty doctor. Today, I'll be discussing scout-guided excision of non-palpable breast lesions. It's an institutional experience. It's quite a newer technique to localize impalpable breast lesions. So I'll be sharing our experience with this new technique. As we all know that there is improvement in breast screening services over the time, and we are seeing rise in referrals from screen detected non-palpable cancers. The importance is that accurate lesion localization is crucial for successful therapeutic outcomes. Wire-guided excisions have long been the standard for localizing all these lesions, but this technique comes with some challenges, um, whi- which includes wire displacements, wire dislodgements, patient discomfort, and listing issues, especially affecting surgical and radiological scheduling, and delays in surgery or cancellation of the surgeries. There is a trend of world of moving towards wireless method of localization, some of which are radioactive seed use and MEC seed use or intraoperative ultrasound guided excisions. Um, Among all these things, Savvy Scout is an innovative localization method for impalpable breast lesions. it uses a radio frequency identification system. SEVI Scout consists of a small reflector, this one which is deployed in the breast, in the lesion, and then on the day of surgery, a console and a guided probe is used to localize this. I've got a small video to show how it works. So with this system, we deploy this reflector in the breast lesion.
Well, we are still at the introduction on your slide. So are your slides moving on? Yeah, now. And
Should I start from?
no, it's okay. We got the introduction. Good. Yeah, there we
That's
go.
the wireless wire-guided excisions we do, and these are the limitations we see.
That's
Now,
good.
am I up to with my slides?
Okay.
So now the new innovation is a SEVI Scout. This is how a Scout system looks like, with a small reflector and then the console for signal detection. Can you see this little video?
Yeah.
So we deploy this tiny reflector in this breast lesion way days before the surgery, and on the day of surgery we use this guided probe, and this guided probe tell us the distance of the probe from the reflector, and this distance can be measured in millimeter on the console. It also sends some audio signals like some beepings which guide us how directly or how much aligned we are with the reflector from our probe. This technique can also be used for lymph node localization, which is really important for targeted axillary dissection as the world is moving towards less surgery in axilla. So after chemotherapy, it just helps us for targeted axillary dissections. The objective to carry out this study was to assess the effectiveness and outcomes of Scout guided excision, mainly focusing on accuracy of lesion localization and efficiency of the procedure, and the overall procedural success. We collected the data from February 2023 to June 2024 of all the patients undergoing Scout guided excision, and evaluation criteria included histological findings and operator feedback on lesion excision. 72 scouts were used in 67 patients. All our patients were female. The mean age of the patient was 60 years, ranging from 41 to 86 years. 97% of the scouts were deployed in the breast, whereas 3% were used for targeted axillary dissection to localize lymph nodes in axilla. 5 were the cases in which we used multiple scouts. 3 cases were of multifocal lesion localization, and 2 cases were the one in which we used a scout in breast as well as axilla. Among all these procedures, 76% were therapeutic, whereas 23% were diagnostic, and 13.8% were the procedures which were carried out after neoadjuvant chemotherapy. The duration of scout insertion to excision time varied. In 4 cases, we inserted scout on the same day of surgery, and there were cases in which we have inserted scout 7.5 months before when the patient was starting neoadjuvant chemotherapy. Our results showed that 70.83% of the lesions which were excised were malignant, 2.7% were benign, 2.7% had DCIS, and other lesions shows either D3 or other lesions, papillary or ADH. Post-surgical margin status showed that re-excisions were done in 15.27%, which were 11 patients which required re-excision due to closed or involved margins. Well, it is within the NHS criteria of re-excision limit, which is 16 to 18% acceptable in NHS. Whereas on review of these re-excisions, we found out that most of the patient, like 63% of re-excisions had histology and radiological discrepancy. The initial imaging showed that the lesion is smaller, but on histology, there was a significant discrepancy. Specimen X-rays were conducted after scout excision in 72% of the patients. That was done during the training period when we were initially starting with the scout use. As far as the complications are concerned, only one patient has post-operative hematoma, which was managed conservatively and didn't require any exploration for that. No other complications were reported. We were able to retrieve all scouts. No device malfunction or failure was noted. No delay or cancellation or surgical list was there. We find out with this study that it's a highly reliable and efficient way of localizing the lesions, and there was no significant impact on surgical scheduling. Margin involvement was there in some cases, and size discrepancy between histology and radiology was there. Conclusion is the same, that it's highly reliable, accurate, and consistent technique to localize these lesions. Our future direction will be working on preoperative imaging and addressing the size discrepancy. Thank you.
Thank you very much.
So, an interesting study. So, I didn't get how many, what were the numbers of your cases? 50?
So 72 scouts were used, and the total number of patients were 60.
Yeah, the discrepancy, what was the number of percentage of discrepancy in your cases?
The discrepancy was, so the re-excisions were 15%, overall re-excisions were 15%, but in those 15%, 63% patients were those in which the initial imaging showed that the lesion is smaller, but when we excised it, we found out that the size of lesion was way much more bigger on histology than what was reported on radiology.
Yeah, okay. So basically there's quite a significant margin of improvement with this, because you would want this 15% percentage to kind of come down significantly for this to be more beneficial.
Yes, there is a margin of improvement, definitely, but still the NHS has a cutoff for re-excision, which is 16 to 18%. Still, we fall in that criteria, but we do understand that there is some margin of improvement, and the re-excisions can be brought down much lower if we just work on the radiological assessments.
Thank you.
Symbol, my question. This is a new technique, radio frequency localization, and you put a bead, so to say, to localize. Is that right?
Yes.
And is that bead passive, and the radio frequency just picks up the localizer? It doesn't emit.
It's not a bead. It's not radioactive. It's a small, I would say, a metallic chip, you could say. And then it just used radio frequency waves. There is no radioactive material, which is a good thing. It's MRI compatible. So this is again a good thing. And it can be put in the breast and can be left for a longer period of time.
Okay. Were you able to draw a comparison with the technique used in terms of wire localization? Were you able to draw a comparison with that technique to bring forward?
I haven't done it today, but I am working on this project, so I could just give you some vague analysis what I am going through. Like what I'm seeing, I'm already working on a study which is about the comparison of previous wire guided excisions and the one we are doing with the Scout. Definitely, there is a decrease in margin excision rates, and with the wire guided excisions, we did had some unfortunate events in which the wire was dislodged and the patient had to go back from the theater, and or the wire was dislodged and was not in the right place, and we took out the normal breast tissue and there wasn't any cancer on the histology. So there were some unfortunate events with the wire guided excisions.
Okay, thank you very much.
Thank you.
So our next speaker is Dr. Shadab Ehsan from Shaukat Khanum Memorial Cancer Hospital Research Center, Peshawar. Dr. Shadab is going to speak on outcomes of liver resection in Shaukat Khanum Memorial Cancer Hospital and Research Center, Peshawar.
Assalamu alaikum. I am Dr. Shadab Ehsan, resident surgical oncology at Shaukat Khanum Hospital, Peshawar. And today the topic of my presentation is outcomes of liver resection at Shaukat Khanum Memorial Cancer Hospital and Research Center, Peshawar. Liver cancer and intrahepatic bile duct cancer incidence in Pakistan is 4.4%, in which 80% of patients are viral hepatitis based. The lack of awareness and screening programs contributes to late-stage diagnosis. Liver resection is a key component for management of liver cancer. Laparoscopic liver resection may have superior outcome as compared to open liver resection. The aims and objectives of our study includes the primary objective of this study was to analyze the outcomes of liver resection performed at our hospital, and the secondary objective was to compare outcome of laparoscopic versus open liver resection. The study design of our study was retrospective cohort study done at Shaukat Khanum Hospital, Peshawar from May 2021 to July 2024. Our inclusion criteria includes all those patients who were referred from hepatopancreatobiliary MDT for liver resection, and exclusion criteria exclude all emergency surgeries and irresectable diseases or disease with METs. Our sample size was 66, including 37 females and 29 males with mean age of 50.36 plus minus 12.65 years. Our 50% of patients were from the age between 46 to 60 years of age, and 22.73% of patients were in the age between 30 to 45. In distribution, our 28.8% of patients were having colorectal liver mets, and 25.8% of patients were having hepatocellular carcinoma. Our 28.8% of patients were positive for Hep C, and 24.2% of patients were diabetic. Most of the patients, which were 44 out of 66, had open surgeries. No significant association exists between age and type of procedure applied. We had performed minor liver resection and major liver resection. 21 cases of major liver resection and 39 of minor liver resection. We had performed some laparoscopic surgeries and some open liver resection, and which 27 out of 66 were laparoscopic, including 5 majors and 22 minor. And open surgeries, we had 44 surgeries, 22 major and 22 minor. If we look at the outcome, there is no significant difference as observed, but only in length of hospital stay. And complication and laparoscopic surgeries performed, we had only one patient of bile leak, but in open, we had 2 patients and post-hepatectomy liver failure, 4 relook, 2 bile leak, 1 surgical site infection, 1 readmission, 2 30 days mortality, and 1 90 days mortality. And post-op histology, we have observed that the metastatic adenocarcinoma is the mostly observed histopath, followed by moderately differentiated adenocarcinoma. And post-op findings, our 85% of tumor resection achieved are zero margins, which include that there is no microscopically residual cells of cancer were present, indicating complete removal. And 15% of cases were R1 margin positive. It means that microscopically there were there were cancer cells present, indicating high risk of recurrence. If we divide the R1 subdivision, and out of 10, R1 margin cases, 3 were colorectal liver mets, 3 were hepatocellular carcinoma, 1 in gallbladder cancer, 1 in hilar cholangiocarcinoma, and 2 in cholangiocarcinoma. And long-term outcomes, laparoscopic were having 0 30 days mortality, 0 90 days mortality, 7 recurrence, out of which 16 patients are alive and 3 are dead. And open, 2 30 days mortality, 1 90 days mortality, 19 had recurrence, 27 are alive, and 10 are dead. Our study highlights that liver resection remains an effective treatment option for liver cancer, with a high rate of complete tumor resection achieved in 85% of cases, similar to the oncological outcomes reported in Orange trials. Orange 2 trials demonstrate that laparoscopic surgery leads to a faster recovery, and our study demonstrated exactly the same result with laparoscopic of mean hospital stay 4 versus open, which is 5. Instead of faster recovery, no statistically significant changes observed between the two modalities, but still this study may conclude that the laparoscopic is safer than open surgery in terms of complication. This is the comparison of our study with Orange 2 trials, indicating that there is no significant difference observed between these two studies, but our limitation was less sample sizes compared to Orange 2 trial, and the duration of study of our study was 3 years, and on Orange 2 was having 5 years of study time. There is the references, and thank you.
Okay, Shadab, very nicely presented. And I must congratulate your whole team and department, on having this, achieving these results. So just a quick question. You mentioned about major liver resections and minor liver resections.
Ji.
Can you elaborate a little bit more about major and minor? Secondly, based on this data, would you recommend a laparoscopic resection for every case, or would there be any criteria for that? Thank you.
So the major liver resection indicates that if we had done left hepatectomy, right hepatectomy, left extended hepatectomy, and right extended hepatectomy. In minor cases, we included all the anatomical resections, non-anatomical resection like 2, 3, 4, 5, and 7 segment resections, left lateral resections, and posterior segmentectomy. On the basis of this study, instead of faster recovery and less hospital stay, we cannot comment on this thing that we should have done the laparoscopic surgeries more as compared to open surgeries. But if we keep this thing in mind, that hospital stay, and in terms of hospital stay, then we can recommend for hepatectomies, laparoscopic techniques.
So, again, kind of similar question. Where do you draw a line between laparoscopic and open hepatectomy?
And-
What makes the surgeon go for an open, even though laparoscopic surgery is available and it's done for hepatic carcinoma?
In terms of outcomes or sort of complication, if you look at the complication, then we had less complications and laparoscopic compared to open liver resection.
Okay.
Work done with your team on this disease. Excellent. Good work. Moving on. We'll move on to the next speaker, who is Dr. Arub, and it'll be an online presentation, and it's going to be regarding sphincter preservation in anastomotic leak patients following low anterior resection, a novel technique. So, Dr. Arub.
Assalamu alaikum, everyone. Can you hear me?
Yes, we can.
Okay. I'll share my screen. Can you see the screen? Is my screen visible?
We can hear you. Please continue. Thank you.
Okay. Assalamu alaikum, everyone. I'm Dr. Ruby Idris, working as a resident surgical oncology in Shaukat Khanum, Peshawar, and I'm going to present sphincter preservation in anastomotic leak patients following low anterior resection, a novel technique. So colorectal cancers, it is basically the second most common cancer, and 1/3 of which is the rectal cancer. If rectal cancers do not involve the sphincter, then we do sphincter preserving surgeries, that is low or ultra low anterior resection with colorectal anastomosis and covering ileostomy. After the surgery, anastomotic leak is one of the most feared and dreaded complications, with the increased risk of early and long-term morbidity and mortality, increased hospital stay, and drainage of the hospital resources. Hence, it requires prompt intervention. Anastomotic leak occurs in around 1% to 20% of the colorectal anastomosis. Mortality associated with the anastomotic leaks is around 1.7 to 16.4%. And we divide the anastomotic leak into 3 grades. In grade A, it is a subclinical leak. It requires no therapeutic intervention. Grade B has a clinical manifestation and it requires conservative management without surgical reintervention. Grade C, it requires surgical reintervention. Now, anastomotic leak is usually diagnosed within the first 2 weeks after the surgery. Around 47% of the patients, it is diagnosed after the patient had been discharged. Hence, we divide the anastomotic leaks into early and late leaks. Early leaks, they are diagnosed within the first 6 post-operative days, while late leaks, they are diagnosed after the 6th day. We diagnose the anastomotic leaks on basis of the clinical signs and symptoms experienced by the patient, some laboratory findings, that is leukocytosis and raised inflammatory markers. Then we do CT scan, in which we can see the fluid collection or contrast extravasation. Then we do flexible sigmoidoscopy, which will locate the site and size of anastomotic leak. So the question we had in our mind was that can the anastomosis be salvaged and preserved conservatively without any surgical reintervention in anastomotic leak patients following low anterior resection? Our main objective was to evaluate the efficacy of conservative management in treating anastomotic leaks and preserving the sphincter. For that, we did retrospective data collection of all the rectal cancer patients who underwent low or ultra low anterior resection between April 2021 and August 2024. On the patients who had biopsy-proven rectal cancers and they underwent low or ultra low anterior resection with colorectal and coloanal anastomosis were included in the study, while on the patients in whom no anastomosis were performed or who had metastatic tumor perioperatively or on imaging were excluded from our study. A total patients of 143 were studied. Among them, 100 were male and 43 were female. Among the 143 patients, 7 patients had an anastomotic leak, which makes around 4.89%. Among the 7 patients who had the leak, 3 were managed through surgical intervention, while 4 were managed conservatively without any surgery. So patients who underwent the sphincter preserving surgeries, they were total 143. 136 patients had no anastomotic leak, while 7 patients had an anastomotic leak. Among the 7 patients, 4 were managed conservatively, while 3 underwent reoperation. The 4 patients who were managed conservatively, among them, 1 patient underwent endoscopies only, and he was kept under observation, while 3 patients had endoscopy plus endosponge placement. The 3 patients who underwent surgical reoperation, they had completion proctectomy. Mean hospital stay was 23 days with no mortality reported, and total number of endoscopies performed were 6. From 4 to 11 endoscopies were performed. Our conservative management included intravenous fluid administration, which is the initial resuscitation, and broad-spectrum antibiotics were given to prevent any infection. Then we kept the patient nil per mouth. Then while doing the flexible endoscopy, the rectal wash was done with a lot of water. Then if the placement of endosponge was required, it was done right at that moment. Here's the endosponge technique. So initially, a flexible sigmoidoscope is inserted and it is placed within the cavity. Then an overtube is inserted into the cavity and the size of the cavity is measured. Then the endosponge is cut according to the size of the cavity and it is pushed in the overtube with help of a pusher along with the drainage tube. When it is positioned within the cavity, it is left over there. The basic mechanism of the endosponge is that it creates a negative pressure. So it helps in the continuous drainage of any secretions or pus or fecal material which is produced within the cavity. It helps in debridement, so it prevents wound infection. It helps in the granulation tissue formation, and with the time, it keeps on decreasing the size of the cavity. So after every 3rd or 4th day, we change the endosponge and we cut it according to the new size of the decreased cavity. Here are some endoscopic pictures. This is from the patient who underwent endoscopies only. So this is day 1, in which we can see there is a small defect. There was no pus and no cavity formation. It has started healing. Granulation tissue has formed and the cavity is healing and it has completely healed. Then it is the next patient who had this large defect. Endosponge was placed and then we can see it has healed completely. This was from So endosponge is a viable first-line treatment for localized leak patients who are stable and they do not require any surgical reintervention. It reduces morbidity and mortality associated with re-exploration, and it improves quality of life as it preserves the sphincter and prevents tumor formation. The references. Thank you so much.
Presentation, a novel way forward. What's the cost of this endosponge? Can you hear me?
Yes.
Can you hear me? I just wanted to ask, what's the cost of this endosponge? I think, can you hear me?
Normally, if the TV they are very expensive, normally we get by ourselves, which is sterilized and. So normally the pre-made one will be very expensive. We make it handmade, sort of, with the sterilized sponge, and we use a drainage, which can be from a soft one from a JP drain or any ready-wake drain with multiple holes, and we stitch it around the drainage pipe and connect it to a low suction machine. So if we consider that it's a pre-made and the whole costing, it will be very expensive. But if you improvise it, it comes very handy.
That's the next. Even if the cost was expensive, I think the outcomes certainly about demand that is done, it improves the quality of life. Yes, the outcome.
Sorry, hi, good morning. My apologies, I came late to your presentation. Coming back to the previous comment, the cost in Europe for this, which is a single-use disposable kit, is about 5,000 euros. It's an expensive kit. It requires at least 4 to 6 median changes. So you could see the cost escalating. I know the group here have done the modification and they managed to do this with a very low cost and very good outcome. Now, the question for me, if you could hear me, I know the guy sitting in the room, is that most of the low rectal cancer leaks often go undetectable. They don't become clinical because most of them are defunction. So is there a role of doing a routine endoscopy on day 4 and 5 to pick these leaks early and initiate the treatment of endosponge if it is needed? Or do you think we have to go with a symptomatic? Because by the time patient becomes symptomatic, they usually have taken a systemic hit, either localized or generalized, because there is a big drive now in some centers in Europe doing low anterior section without ileostomies, and they're very aggressive with endoscopy on day 4, seeing the defect and treating it either with primary suturing transanally or using an endosponge technique. So any comments from the guys who are using it here, or maybe the speaker? You must have read a lot more than most of us. Enlighten us on this.
Thank you, Prof, for this question. Yes, indeed, we can do this. We haven't done this before, but my point on this is that it'll lead to quite a lot of sigmoidoscopies. We only have one gastroenterologist available and at Peshawar. So yes, we don't have we can do it, not the flexible one, but with the rigid one. Yes. Yes, absolutely. But yes. So that's unfortunately, one thing that, so the sigmoidoscopies has to be done by a gastroenterologist in our department, in our hospital. So yes, but it will lead to, quite a lot of, yes, absolutely. To be honest, yes, if Dr. Shahid, we used to do it, sigmoidoscopy, even just after we have done the anastomosis, just to check the bleeding. So that's not the, case. The anastomosis won't disrupt if it is, done properly and everything. So I won't be worried about that. The anastomosis, it'll just be, the logistic bit of it.
But if you look at it from the other perspective, won't that be an overkill? That doing endoscopies for every patient on the 4th postoperative day, considering there might be someone who is not progressing normally as we would have expected. So those can be categorized as high risk and we can do it for them.
I think the gist of my comment really is you missed it. If you got a leak rate of 4%, which is excellent, I saw it. So I could easily argue to you that 96% of your stomas are unnecessary. Why are you giving them ileostomies? Because your leak rate is so low, right? So the purists who are trying to get rid of this stoma are arguing that we need to pick these non-symptomatic leaks early as well. And yes, it is a hard work. It requires you to come in and do the scopes on day 4, not relying on your colleague. It is you who have to take them back to theater for different sessions and so forth. But this is an ongoing debate now in Europe because this is an important aspect to think about. Ileostomies or covering ileostomies or colostomies are not without consequences. They have morbidity, they have problems with readmissions, and there are mortality associated even with a smaller loop. I lost a patient covering loop ileostomy reversal with cardiac event. So, we're just making a comment. I'm not sort of necessarily advocating that you should take everybody on day 4, but think about it. Maybe in a selective cases, maybe who are high risk, as you mentioned, male, heavy BMI, post-radiation, coloanal joint, have a look at the bottom end. And if they have become symptomatic, do endosponge treatment early because it has 2 consequences, leaks. Obviously, the functional aspect, which become a problem long-term, and obviously systemic hit has got a problem with survival long-term. So this is where the comment really was, not necessarily asking you to do endoscopies.
This is question, Shahid.
Yeah, just a comment on that. Yes, anastomotic leak is always a challenging and it remains a problem for colorectal surgeons. And there are few new devices are available, like intraluminal eye, which we've been recently trying to get it, which is basically a rigid scope, and it has anybody can do it, and it has a LD screen, so you can look at it. Patient who you think clinically might got some problem with the anastomosis, you can actually do it in the ward, that rigid scope with the camera and and then you can decide that this is the leak or this is the leak which needs intervention, and then you can go to the next, like endosponge or endoscopic suturing or whatever. But that is a device which is now available and will get more and more available across. And this is something you can do in selected cases.
Yeah, can I make a comment as well from Irfan and go on? Or these 4 patients which had an endosponge, you know, when do you reverse their ileostomies? You know, is it the normal time or do you give? Because I don't know the answer. I have got quite a few patients like that, and you are always a bit skeptical. You know that whether should I leave it for 3 months? Should I leave it for 6 months? Should I leave it for a year? And in fact, one of my patients whom we did endosponge, everything went well, fine, you know, and after we reversed the ileostomy, we found a collection again. So what is your experience in these four patients that you had?
Did a scan on them. Once we did a sigmoidoscopy, the last sigmoidoscopy was fine. There was nothing. Then I did a scan on them. And in about 6 to 8 weeks time, we just reversed them. And they all went fine, alhamdulillah. And there were no bowel, the problems with the bowel functions. So the sphincter functions and everything were fine. So in 6 to 8 weeks time, after the last sigmoidoscopy, once that's fine. So I tend, and the CT, and I really do the CT scan. There was no collection. The collection is resolved. And then, we reversed them. Thank you.
I think we'll, thank you very much. Our next speaker is Mariam Asad from Shaukat Khanum Memorial Cancer Hospital Research Center, Peshawar. And she's going to speak on enhancing clinical outcomes across successive generations through standardized training programs.
Assalamu alaikum and good morning, everyone. I'm Dr. Mariam Asad, working as Fellow Surgical Oncology at Shaukat Khanum Hospital, Peshawar. Today, I'm going to talk about impact of standardized training programs across successive generations of surgeons. So as the landscape of surgical procedures continues to evolve, so must the methods by which the surgeons and the trainees are trained. The transition from the traditional open surgery to the laparoscopic procedures necessitates a paradigm shift in surgical training programs. So the importance of hands-on training in laparoscopic surgery is of crucial importance as it helps one to master and precise the complex laparoscopic movements required in the procedures. It can be incorporated into the training program via simulation-based training and cadaveric training workshops, which provides a risk-free platform for the trainees and fellows to refine their skills. And lastly, the most important is the mentored surgical practices, which involves an experienced surgeon overseeing and guiding the surgeons and the trainees as they perform operations. So this is from the excuse me, this is from the consensus meeting of European Academy of Colorectal Surgeons, where a draft was proposed for a modular structure standardized training program for laparoscopic colorectal surgeries. So the objective of our study was to evaluate the long-term impact of standardized training program on clinical outcomes and determine their effectiveness in sustaining high-quality care across generations of practitioners. So it was a longitudinal study was conducted across multiple healthcare institutions, implementing a standardized training program, and successive cohorts of trainees' data were analyzed to assess the durability of the training's impact on the clinical outcomes. So I'm going to talk about the results We basically compare the results of 3 generations of surgeons. So the first generation of surgeon and the mentor, Amjad Parvez, he had performed 263 cases of laparoscopic rectal surgery, and this was back from 2016 to 14. And we're only going to talk about the standardized laparoscopic mesorectal excision for the rectal cancers. So he trained 3 fellows who eventually went and performed the same way of laparoscopic mesorectal excision for rectal cancers, and they had a collective number of 116 patients. And they further trained 2 fellows for the same procedure, and they had a total number of 238 cases starting from 2021 to May 2024. So I'm just going to talk about the results of the last generation of surgeons, and then we're going to compare with the previous ones. So we had a total number of 238 cases, out of which 70% were male and 30% of them were females. So the open conversion rate was 0.4%, 30-day mortality was 0.42%, and major complications, including the anastomotic leaks and post-op bleeding, was around 9.6%, and R1 resection rate was around 2.9%. So the lymph node harvest was around 18. So we compared it with the results of the previous 2 generations of surgeons. So the perioperative variables, the rate of conversion to open was 1.50% in the first generation, 2.60 in the successive generation, and lastly, it was 0.40%. Here, I would like to highlight the fact that it was back in the day when there was much, much higher rate of conversion to open, and there was much higher mortality rate as well. So the lymph node yield was 14 in the first generation, 16 in the second, and 18 in the third generation of surgeons. So in post-operative variables, we compared the 30-day mortality rate, which was 0.76% in the first generation, 0% in the second generation of surgeon, and 0.42% in the last generation of surgeons. Major complications were around 19.40% in the first generation of surgeon and 9.60 in the third generation of surgeon, which include mainly the anastomotic leaks and post-op bleeding as well. R1 resection margin was 3.43% in the first generation, 2.59 in the second, and 2.90 in the third generation of surgeon. As you can see that the results of the third generation was probably more than the second. It was because they had more locally advanced cancers presented at the center. So standardized training programs are crucial for achieving and sustaining persistent clinical improvements, and their ability to influence successive generations of healthcare professionals reinforces the need for continued investment in such programs to ensure ongoing advancement in patient care and clinical outcomes. Lastly, I would just like to say that we being the 4th generation, there's a lot of pressure on us, and we hope that we can continue to maintain the same standards and keep making our mentors proud. Thank you very much.
Thank you very much for your excellent presentation. May I know, was there any advancement in the instrumentation and, of course, the technique through the years that the study was conducted?
Okay, thank you for that question. Basically, the instruments and the advancements, they do play a role, but it was our focus was to see that modular structure standardized program, do they have role if performed across the successive generations of surgeons? And it does, because if we talk about the first generation, they were the ones who were the pioneers, who were working on it to make one structured program. And then the second and third generation, they had a benefit that they already had some standard techniques to follow, and then they can improve their results as well with that.
Thank you. Yes, please. Amjad.
I had an easy job because my numbers were bad. So they have got much tougher job now to improve 0.4%. So good luck to them. A question that you asked, obviously there have been improvement, not necessarily just in the technical aspect. MRI have got better. We start reporting EMBI, we start looking at the margins more carefully. So the improvement happened in a linear fashion, not necessarily on a technical skill itself. Obviously, these guys are very gifted surgeons. They have come home and set up a fantastic program. But we also have got better with radiology, patient selections, people who need to go for new adjuvant chemoradiation that have played a role. So I think all of this has to improve. Any structured program that you advocate and say, this is excellent program has to be reproducible and generalizable. So, there's no point me doing a fantastic operation that nobody else could do, because then there is a problem. So I hope that these young guys who come home and, they're going to train the next set of generation of people who learn this. But I would also emphasize improvement in allied specialties as well, particularly with MR radiology. I have been coming to Pakistan for a number of years, and my general sort of feeling is that we are really very weak on radiology, rectal radiology. Surgical skill in rectal cancer is largely determined by a very good radiologist telling you the MR pictures, and then a very strong MDT. So if you improve all those, each success become much bigger success. So take them along. Don't just rely on laparoscope.
Okay. Okay. Thank you very much.
Thank you. I concur with your comments. It's also establishing a team that will reproduce the results each time. And I think from OR text to radiology diagnostics and nursing, I think it all adds up. So I think that goes in terms of establishing a team and, of course, a structured program for everybody. Thank you.
Thank you very much.
Moving on, we'll go on to the next presentation, which is going to be by Dr. Rimsha Afridi from SKM Peshawar, and she's going to talk about discrepancies in MRTRG grading system reliability and its impact on surgical planning for rectal cancer, insights from a retrospective studies. Okay, we'll move on to the next one, which is an online presentation by Dr. Fatma Sarfraz. And she's going to talk about adjuvant chemotherapy versus surveillance in stage 2 colon cancers, a comparative analysis at Shaukat Khanum Memorial Cancer Hospital and Research Center, Peshawar.
Assalamu alaikum and good morning, everyone. Am I audible? Assalamu alaikum.
We can't hear
Assalamu
you.
alaikum and good morning, everyone.
Thank you.
Am I audible?
You are, yes. Go ahead, please.
Okay. Assalamu alaikum and good morning. I will be sharing my presentation, which is a research on the research based on the colon cancer stage 2, and it compares the survival analysis between the patients who received adjuvant chemotherapy versus the patients who were put on surveillance and were closely monitored. It was a comparative analysis which was performed at Shaukat Khanum Memorial Cancer Hospital and Research Center. So, a snapshot of my presentation. The research project that we conducted was basically a retrospective cohort, and it compared the survival analysis among the groups of the patients which were either put on surveillance or received adjuvant chemotherapy following their diagnosis of stage 2 colon cancer. And the survival benefit was measured in the terms of disease-free and overall survival. For the background, colon cancer is the most common malignant disease, and it is predicted to claim the lives of 53,000 Americans per year, which is equivalent to a drastic figure of 145 people per day. So basically, radical surgery is done with the curative intent for stage 1 cancer and for stage 3 and beyond, adjuvant chemotherapy has its significant impact for the survival benefit. Whereas for the stage 2 colon cancer, which forms a major bulk of the disease, with 30 to 40% of the patients presenting at stage 2, radical surgery is recommended with the curative intent. However, the survival benefit of adjuvant chemotherapy is shown to be as low as 5%, and there are no clear, straightforward guidelines as to what to do about the adjuvant chemotherapy. Whereas the European Society for Medical Oncology and the American Society for Clinical Oncology both recommend that postoperative adjuvant chemotherapy should be reserved for the patients who have high-risk features, such as inadequate nodal resection, which is that resection of less than 12 nodes, T4 stage at diagnosis, or diagnosis in the setting of bowel obstruction or perforation, and an imminent need for an urgent operation, poorly differentiated histology, or peritumoral invasion, either lymphatic or vascular. These bad prognostic features may reasonably prompt the physicians to consider adjuvant chemotherapy. However, despite being linked to the worst outcomes, there is not enough evidence that these features are the indicators of a positive response to adjuvant chemotherapy. Hence, the aim of our study was to evaluate the outcome of patients who were diagnosed with stage 2 colon cancer and presented to our institute. And after receiving this means the primary surgery, they were either kept on surveillance or they received adjuvant chemotherapy. And the purpose of the study was to further investigate that which subgroups of the patient actually benefited most from the adjuvant chemotherapy. We began the study by seeking the ethical approval from the Institutional Review Board of Shaukat Khanum Memorial Cancer Hospital and Research Center. The data was collected for over 4 years of duration. That is, we began from January 2017, and the data was collected till December 2021. The sampling technique that was employed was non-probability purposive sampling, and the SPSS version 26 was utilized for all sorts of analysis. So this is the snapshot of the cohort that we had. We had a total of 246 patients, out of which 106 patients received adjuvant chemotherapy and 140 patients were closely monitored. Subgrouping of these 246 patients showed that 205 patients had T3 and NOT disease at their initial presentation, whereas 33 patients were classified to have T4A and NOT disease, and only 7 patients had T4B and NOT disease. I will start with the endpoint of our results, or the survival, which is either recurrence or mortality. So we'll be seeing the worst things that happen first. So out of the total cohort of 246 patients, only 18%, that is 7.3% of the patients, had recurrence or disease progression. Out of these 18 patients, 10 patients belonged to the group that received adjuvant chemotherapy, and the other 8 were from the group that was on surveillance. Unfortunately, it might be a coincidence, but there is a unique feature, as you can see here, that the patients who underwent right hemicolectomy were the most to have reported recurrence in the both groups, which can be a basis of another future research. Coming to the mortality, the adjuvant chemotherapy versus surveillance, the patients who were in the adjuvant group, there were 6 mortality incidents, whereas 5 among the group that was on surveillance. Now the curves which give the gist of our analysis or our study. So we have Kaplan-Meier curves reporting the survival in the terms of overall survival and disease-free survival. We have the subgroup analysis of T3 and NOT patients first. I would like to simplify things for you. As you can see that there are green and blue lines in the Kaplan-Meier. The green line is basically representing the cohort of patients that were purely on surveillance, whereas the blue line represents the group of patients that received adjuvant chemotherapy following their surgery. As you can see on the first graph on the left, in overall survival, that the patients in the adjuvant chemotherapy group tend to fall down after a 3-year mark to a percentage of 94% of survival, which is good. But if you see the survival benefit of the patients who were just under surveillance, it maintains a pretty flat curve and stays close to 98% at 5 years and even beyond. Seeing the disease-free survival curve, the results are typically dissimilar. The survival analysis is 97.6% for the patients who were in surveillance groups and 94.6% for the patients at 5-year mark who were in the group that received adjuvant chemotherapy. I would also like to mention that out of these 205 patients that were subgrouped as to have T3 and not disease, only 88 patients received adjuvant chemotherapy, whereas 117 patients were closely monitored. So a picture is worth 1,000 words. As I've changed the graph, I do not need to say much. As you can see, the survival has drastically changed for the patients who, as we change the stage of the disease and move to T4A disease. The survival analysis shows that the patients who were in the surveillance group did not show good or promising results as compared to the patients who received chemotherapy in this particular subgroup of the patients. The survival is dropping to almost 70 to 68% for the patients who, in the terms of overall survival for the patients who were in the surveillance group, as compared to survival seeing close to 90% at 5 years mark for the patient who received adjuvant chemotherapy. When we come to the disease-free survival curve, the survival drops drastically, rather steeply, in the patients who were just purely on the surveillance. Unfortunately, most of these patients had mortality or recurrence. But another significant thing about this analysis is that there was a small number of 33 patients in this group. The patients who received adjuvant chemotherapy were only 21, and those on surveillance were even smaller, which is a number of 12. Moving to T4B and not disease, the number go even smaller. We only had 2 patients in the surveillance group, and one of those patients expired following the recurrence of the disease. That's why the graphs are very similar. However, the other 5 patients who were in the adjuvant chemotherapy group maintained a survival at 100% at even 5-year mark. Both of these findings for T4A and T4B suggest that there is a clear-cut benefit of giving adjuvant chemotherapy to the patients who have higher stage of the disease at initial presentation or have certain other high-risk factors. But further studies need to be done with larger cohorts and probably prospectively. Coming to the other variables of our study, we also evaluated the microsatellite instability indices. Unfortunately for the patients that were included in our study and were operated initially in 2017 and 2018 did not undergo MSI testing, and it formed a larger pool of the patient, that is 43% or 46 patients per se. The rest of the patients who underwent MSI testing, out of these 23% of the patients out of the total, had the indication to receive adjuvant chemotherapy as they showed deficient MMR or MSI with high instability. MSI was stable for 36% of the patients. Coming to the other high-risk features, the patients who received adjuvant chemotherapy, out of those, 24 patients had T4 disease. Other 21 patients had poorly differentiated carcinoma at the time of their diagnosis. 12 patients had less than 12 lymph nodes during their surgery. 7 patients presented with emergency in the form of the obstruction. And 3 patients each were in the group of perineural or lymphovascular invasions.
You have 1 minute, please.
Although these, okay.
You have 1 minute. Go ahead, please.
Okay, sorry, I thought you asked me to stop for 1 minute.
No,
Okay, so the conclusion. Okay, so the conclusion and limitations for our study indicate that the patients under surveillance demonstrate better disease-free survival and overall survival at 5-year mark rate for the patients who have T3 and not disease at their presentation, opposite to the patients who have T4 tumors. Notably, our study was retrospective and involved a relatively small sample size, which limits the generalizability of our findings, as well as the survival analysis of patients with high-risk features. Additionally, many patients did not undergo MSI testing to begin with. So further investigations and further studies are indicated to go further with our implications. But this study has indicated that there is no clear-cut benefit in giving adjuvant chemotherapy to the patients who have T3 and not disease at their presentation. Thank you so much. These are the. Thank you so much.
Coming towards the introduction, I would like to share the idea behind why MRTRG grading was needed. So, as we are all aware of the fact that rectal cancers are sensitive to chemoradiotherapy, so these radiations induces fibrosis in the tumors, making the post-treatment assessment difficult. Also, the fibrous tissue and the residual tumors exhibit similar T2 signals on MRI scans, making the MRI-based restaging challenging. Now, magnetic resonance tumor regression grading is a method used to see the response of the tumors to chemoradiotherapy through MRI imaging. I've put a simple picture for the purpose of understanding to explain the 5 grades. In grade 1, it shows a complete response to the radiotherapy with no residual tumor left. Grade 2 shows good response with some fibrosis and no residual tumor left. Grade 3 shows less than 50% of the residual tumor. Grade 4 shows more than 50%, but less than 75% of the residual tumor. And grade 5 shows no response to chemoradiotherapy at all. Coming towards the objective of my study, so it was to identify the patients with complete pathological response and correlate it retrospectively with the MRTRG. Secondly, we wanted to see the effectiveness of MRTRG in identifying the patients with complete clinical response to defer the surgery and put them on active surveillance. We have collected all the data retrospectively by using the hospital information system. The duration was from January 2019 till August 2023. The inclusion criteria consisted of all the rectal cancer patients who received chemoradiotherapy and showed complete pathological response after surgery. And we have excluded all the emergency cases and patients under the age of 18. For the MRTRG grading, it was done by the 2 institutional radiologists, and they were blinded to the pathological tumor regression grading of the patients that were involved in the study. Data analysis was done on SPSS version 2022. Moving on to the results, our sample size was 54, out of which 65% were males and 35% of them were females, while the mean age was 43. According to the site of the tumor, middle rectum was the most commonest site that accounts for 37%, followed by the lower rectum, that is 26% of it is involved. Also, the anorectal area was involved in 15% of the patients. Upper rectum was involved in 18%, while rectosigmoid was involved in 4% of the patients. On histopathology, on histopathology, 57% of the patients had moderately differentiated adenocarcinomas, followed by 26% of the patients had poorly differentiated adenocarcinomas. 7% of the patients had signet ring cell. 6% of the patients had mucinous adenocarcinoma. We are left with the 4%, which had well-differentiated adenocarcinomas. So on clinical staging, that was done on pre-neoadjuvant scans. 1 patient had stage 1 disease, 7 patients had stage 2 disease, 45 patients had stage 3 disease, while 1 patient had stage 4 disease with hepatic mets. Out of all these 54 patients, 48% of them had sphincter preserving surgeries, while 52% of the patients had non-sphincter preserving surgeries. And on histopathology, all of the patients showed complete response after surgery. And when we retrospectively looked into their MRTRG, only 33% of them showed complete response, 31% of the patients showed good response, while the remaining ones, that is 23% of them were graded as grade 3, 13% of them were graded as grade 4, and no patient was found in grade 5. So we followed all of these patients till July 2024 and found out that 49 patients
has remained disease-free, while 2 patients had pulmonary mets, 2 patients died due to progressive disease, and 1 patient passed away due to viral hemorrhagic fever. So this led us to a conclusion that the MRTRG system has shown limited reliability in our setup, indicating that only 64% of the patients might be eligible to postpone surgery and put them on active surveillance, while the remaining 36% of the patients would still require surgical intervention. So this highlights the need for enhancements to improve the system's accuracy. The limitations of my study were sample size. As our study was done retrospectively, so such studies are limited by biases, confounding variables, and data quality issues as they rely on historic data. Also, the input from different radiologists should have been considered to avoid inter-observer variability. These are the references, and thank you so much for your patience and for bearing with my voice. I really appreciate that. Thank you.
Thank you very much for your excellent presentation. I believe radiology is a difficult field and a lot depends on image acquisition as well as interpretation. So I'm not a radiologist, neither a colorectal surgeon. So I'll invite comments from the audience and your mentors. Where do we stand on this?
Thank you very much. I think this is a very interesting topic, which is watch and wait program following complete clinical response, right? And the general figure quoted around after chemoradiation is about 30%. You know, I know the group in Rio achieved 50% complete clinical response and make these patients eligible for watch and wait program. I'm not going to go into the details of the program because it requires a lot of logistics, resources, intensive follow-up. So I can understand that you probably won't offer that in Peshawar. But coming back to the difference in terms of, or the variation in terms of pathologists reporting it. So even if they had reported a significant proportion as a complete clinical response on a neoadjuvant setting, you still went ahead and did 50% of these patients had permanent stoma. You know, your APR rate is 52% in these particular patients who were YPT 0.
So,
right?
yeah, actually, those patients were the patients who had showed complete clinical response on their MRTRG, they were offered surveillance.
Yeah.
Yeah, but with the compliance and all of those things that they had to go through, they weren't really relying on that. They opted for a surgery rather than going for a surveillance program. And for the all of those things, so they were being offered like.
Yeah, it's
but
not a trick. It is
accepted.
not a trick question. I'm
Okay.
complimenting what
Okay.
you have just done because you haven't got resources to keep surveying them. So
Yes,
maybe
exactly.
the safest option is to do this.
Exactly.
Also trying to explain that even in an institution like Shaukat Khanum, which has probably got a specialized GI radiologist looking at rectal cancer,
Yes.
see the variation in reporting. So it's a difficult subject. It requires standardization of
Yes,
reporting.
of
And Gina
reporting.
Brown have done that. I just want to ask the guy sitting here that do you also do diffusion restricted images or you only rely on TRG?
Yeah, we do that. I just want to clarify one thing, the radiology reporting, are you talking about the radiology reporting which was done before the operation, or you actually took these 54 patients back to the two radiologists and got it reported again?
Yes.
Yeah, that's what so. No, but going back to Amjad's question, that why, we operated on those guys who got APR. So was these 54 patients, we are talking about, which has got CR, what was their initial reporting? Was it CR on the initial reporting? I doubt, I don't think so, because otherwise you wouldn't have operated on
Exactly.
on the initial report, but you got it reported again to compare the pathological CR with the radiological. Well done, that's very good that you took that initiative to taking them back to the radiologist and tell them, and still there was quite a difference because 60% of them were probably right,
Yeah,
but about
60%,
40%
sure.
of them were wrong.
Yeah, we can say that. So
Let's let me add one thing more to this
sure.
about CR as well. As I've been working in a scam for the last, I think, donkey's years, I have patients who have been reported as CR and then they got local recurrence. Then you start thinking, is the CR a CR?
Yes.
I think this, you kind of mentioned that you hadn't looked into this, but it would have been interesting if the initial report was done by the same radiologist and whether on the repeat review, was the same radiologist giving you the same report or was he giving you a different report? Because studies have shown, and I say that from the pancreas point of view, because we've got this issue in the portal vein as well, where the same radiologist may report it differently in different time frames. And you might find that there's a lot of inter-radiologist variability as well as intra-radiologist variability in this. And again, it kind of points to the fact that making these decisions, just for the audience, again, making these decisions may seem very straightforward in the books, but in real life, they're not easy decisions.
I think I will add one of the comments. So this difference which you found, it's not something we have not got it. In the UK, it's not exactly same. Probably if you have a 40%, there is about 20%. So there is always some difference between the pathological reports and these images which they report. So this would be always a problem. But obviously, doing those type of studies will improve their understanding, our understanding, and hopefully this will get better and better in the future.
Just may I also make a comment? Well, it's really interesting that you looked at this because it's such an important question to be asked. We have looked at our data with portal vein involvement retrospectively and had it looked by 2 radiologists who have reported all the scans, and they were blinded to their results and found that there was a discrepancy of about 10% or more. And these are radiologists who are asking and looking for the questions that are specific with regards to vein involvement. So in this cohort, to see this is not surprising. And it may be an idea that because your hospital has such good data capture, to do something like this prospectively and involving the radiologist, because that will improve your reporting standards as well as the relationship you have with them going forward.
Much for the an excellent talk.
Mic on kar dena.
Beyond tradition in reassessing the need for invasive CBC monitoring in liver resections. And it's going to be presented by Khushbak Zainab from Peshawar SKMC.
Assalamu alaikum and good morning, everyone. Thank you for being here today. I am Dr. Khushbak Zainab from medical officer from Shaukat Khanum Memorial Cancer Hospital, Peshawar. I am here to share a very interesting study I did in SKM Peshawar. It is about reassessing the need of central venous monitoring in liver resections. So basically, central venous pressure monitoring is very crucial during the liver resections due to high blood loss and fluid shifts. And the liver extensive blood supply and route in blood clotting make it very careful to maintain a stable hemodynamic state. So it is traditionally believed to maintain a static hemodynamic state in hepatic liver resections for a number of reasons. Firstly, it provides a real-time insight into the patient hemodynamic and dynamic state for a timely intervention. And secondly, it helps the clinicians to assess the fluid volume status and guide further fluid resuscitation, which is essential in maintaining the stability during surgery. So the objective of my study was to assess whether the routine use of central venous catheters is necessary in major hepatic resections or not, and to challenge the traditional practices and explore further evidence-based strategies to optimize the patient care in liver surgeries without the CVC lines. So moving on to the methodology, it is a retrospective study which is undertaken between May 2021 to July 2024, covering almost 3 years of period. Ethical approval was obtained from the Shaukat Khanum Ethical Approval Board, and the data was collected from both the surgical and the anesthesia notes in the HIS. So moving on to the patient selection criteria, I included all the patients who were aged 18 years and above and undergoing partial liver resections referred from the MDT. And the exclusion criteria was the emergency surgeries. So moving on to the results, the major hepatic resections performed at Shaukat Khanum, Peshawar was around 38% of the patients underwent major hepatic resections and 61% of the patients underwent minor hepatic resections. Only 4 out of the total 55 patients, that is 7.2% patients were having CVC lines during the major hepatic resections. And the indication for inserting the CVC line in those 4 patients was only for the emergency venous access, and there was no other indications for inserting CVC lines in those patients. And all the 4 CVC lines were inserted intraoperatively. Moving on to the demographics and further results, I divided the patients into 2 groups, male and female. The male was total 27 patients, and the females were 28. And around 2 female patients were having CVC lines, and 2 male patients were having CVC lines. And I further divided the patients into 2 age groups, below 50 years and above 50 years. So the patients above 50 years were around 65%, but only 5% of the patients were having CVC lines. And the age group below 50 years was 34% of the patients were falling in the age group below 50 years, and 10% of the patients were having CVC lines. Further, I divided the patients based on the ASA groups, and according to the ASA group, only 1% with CVC line was with ASA 2. 2 of the patients were ASA 3, and 1 of the patient was ASA 4. So 40% of the patients with ASA 3 and 4 were having CVC lines, and only 20% of the patients with ASA 2 were having CVC line. I further divided the patients and according to the comorbidities. So no patients with single comorbs and with no comorbs were having CVC lines. All the 4 patients having CVC line intraoperatively were having multiple comorbs. The average stay for the average stay of CVC line inside the patient was less than 24 hours for 2 patients, and the other 2 had their CVC line removed on the 5th day. Average blood loss was 1300 around 1300 ml, and the average intraoperative fluid intake was 5500 ml. And the average duration of surgery for both the major and minor resections were around 5.5 hours. These are all the surgical complications which were seen in the liver resection patients. And these are the post outcomes. The duration of surgery was 5.5 hours for laparoscopic and 6.5 hours for open surgeries. The blood loss was 200 ml for laparoscopic and 300 ml for the open. And the average length of stay was 4 days for the laparoscopic patients and 5 days for the open liver resection patients. And HDU days were same. The surgical complications were with the post-hepatic hepatic liver resection failure was 2%, bile leak 4%, surgical site infection 1%, and relook surgery was performed in 4 patients. But none of the complications were related to the CVC lines, like superficial or deep wound infections, thrombophlebitis, any catheter malpositioning. Nothing was observed in these 4 patients. So what we are doing with our patients, we are not inserting CVC lines in the major hepatic resections routinely. We divide the patients according to the comorbidities. If a patient is a very high-risk patient, then it is the decision of both the surgeon and the anesthesiologist to insert a CVC line or not. So what we are doing intraoperatively is a direct visualization of the vena cava and intrahepatic veins with grossly or with ultrasound by the surgeon. It serves the purpose for estimating the fluids. And intraoperative management with inserting of two wide bore cannulas and an arterial line for assessing the patient hemodynamic status and administering drugs, or if any blood transfusion needed. And then we are restricting the fluid administration intraoperatively during the hepatic resection and then giving the fluids afterwards. So concluding my presentation with that the routine use of CVCs may be unnecessary, as their overall impact on patient outcome was very minimal and they were not used during the procedure. Decisions on CVC use in liver resection should totally rely on the clinical judgment for fluid and hemodynamic status, and if in case of major blood loss, rather than it should not be rather set a standard. I would also like to add about the cost effectiveness. Each CVC line cost around 15 to 25,000, and by this we are saving a lot on the expenditure on patient by not routinely just inserting the CVC without any purpose. Thank you very much.
Thank you very much for your excellent talk. So, we are using a CVC. It's been in practice for many, many years. And of course, the dependence on and the utility of ultrasound has come through now.
Yes, sir.
So in the perioperative period, that includes the pre-op, intra-op,
Yes,
and then the post-op period. How good are we in terms of providing post-operative ultrasound as a monitoring method to assess for, hepatic perfusion and hemodynamic stability?
Sir, we are actually seeing at the patient vital monitoring. By doing the vital monitoring, the urine output, all of these measures help us indicate about the patient fluid status. And intraoperatively, we can do that with the ultrasound, but post-operatively, we are using these measures to see the patient hemodynamic status, or if the patient needs any blood transfusion on the post-op bloods, we rely on that.
Okay, thank you very much.
May I ask a question, please?
Yes, sir.
Excellent talk, and it's a really important topic, especially when it comes to liver surgery, and especially so for the major liver resections, not for the minors, as
Yes,
you
sir.
rightly highlighted in your talk. How many of the major liver resections had arterial line insertion as well? Do you know?
We do arterial line in all the major resections.
Excellent. The other is just a comment, and the central venous line insertion is partly useful for us to maintain the CVC pressures when the resection is going on. But
Yes,
in
sir.
addition to that, we use the monitoring of how the cardiac filling goes on. And currently we're using monitoring methods like LITCO, where we also look at the echocardiogram function of the heart with a sort of transesophageal probe that is inserted. So all of that is not only to maintain the low venous pressures, but also to be judicious in how you replace the fluids, and also to be able to predict how the cardiac function will respond to after the resection's over. So there are multiple uses of the CFC monitoring that also has to be taken into account. So I think the main thing to understand is that for major liver resections, you mustn't take shortcuts. And what you're doing here is excellent because it is judicious use of the line, and therefore a cost-effective health economics that's also really important.
Yes, sir.
So our next speaker is Nauman Shuja from Shaukat Khanum Memorial Cancer Hospital and Research Center, Peshawar. And Dr. Nauman is going to speak on prophylactic radiation to regional lymph nodes following excision of primary cutaneous squamous cell carcinoma of the limbs or trunk. Thank you.
Hello everyone, Assalamu alaikum. My name is Nauman Shuja, medical officer from Surgical Oncology, Peshawar. And today I'll talk about a novel practice that could probably bring a change to the current practice of the plastic surgeons working across the world. That is on the prophylactic radiations to the regional lymph nodes following the excision of the primary cutaneous squamous cell carcinoma of the limbs or the trunk. So with that, first of all, I would like to apologize because you guys must be tired because I see some guys in the back still talking. So let's go on with the introduction of my presentation. Squamous cell carcinoma is the second most common cause of skin cancer. And the rate of nodal metastasis is around 20%, is suggested by the literature. So the nodal metastases we would like to look at the elective radiations, which will prevent the rate of nodal metastasis in either node negative or node positive patients clinically or radiologically, if a lymph nodes are positive clinically or radiologically. So positive lymph nodes are those patients who are having clinically positive or radiologically lymph nodes, they straight away go for the wide local excision plus the nodal dissection. And those patients who have had negative lymph nodes clinically or radiologically, they either go for surveillance or opt for the elective radiations. And this is the area that my study is based on. So the objective of my study, as you could have seen from the topic of my presentation, is to assess the rate of nodal metastasis in patients who received elective radiations or prophylactic radiation therapy to regional lymph nodes compared to those patients who did not receive that area. All right. So the materials and methods, we took the IRB approval from our institutional review board committee. The study design was a retrospective cohort study from January 12 to July 24 in the plastic surgery unit of Shaukat Khanum Memorial Cancer Hospital and Research Center. We included all those patients who have had a staging of T3 and NOD and T4 and NOD, and a minimum follow-up of 6 months. We excluded all those patients who have had positive lymph nodes, either N1 or N2. And we also excluded the patients who have had stages lesser than the T3, T1 or T2, and also the patients who have had multiple cutaneous squamous cell carcinomas. The demographics was, we had a study sample of patients who have an age range of 17 to 75 years with a mean age of 35 years, and male to female ratio was about 4:1. The minimum follow-up was from 6 months and the maximum follow-up till 10 years. And the mean follow-up was about 2.5 years. In our results, we included total number of 54 patients. And in those out of those 54 patients, 45 patients were T3 and NOD, and 9 patients were T4 and NOD, which is 16.4% and 83.3% respectively. And this is the graph for it, by the way. Moderately differentiated cutaneous squamous cell carcinoma, this grading was found to be the most prevalent among all, followed by the well-differentiated and then poorly differentiated. The most common site involved was the lower limbs, followed by the upper limbs. Trunk was the least involved. And the most common type of surgery performed was the wide local excision, followed by amputations. Now, coming to the gist of our presentation of my study is to look at the radiations to the patients who have received radiations and those who did not receive radiations to the regional lymph nodes after the primary cutaneous squamous cell carcinoma is removed. The radiations patients, radiations in comparison to the staging, the T3 and NOD patients, 22% patients received radiations and 78% did not. And in the T4 and NOD only 11% of the patients received radiations. The rate of nodal metastasis in the radiated group, the rate of nodal metastasis was 31% in 17 patients, and 69% did not have nodal metastasis. Now, comparing the rate of nodal metastasis in comparison to the radiations group and the non-radiated group. In the radiated group, we only had 18% nodal metastasis, but in the non-radiated group, we had 34.8% nodal metastasis, which could somehow sound like elective radiations to the regional lymph nodes is a good step. To summarize my presentation, we saw a higher rate of nodal metastasis in the non-irradiated group in comparison to the irradiated group, and moderately differentiated graded squamous cell carcinomas had a high rate of nodal metastasis, along with the T3 and NOT stages, who have had a higher rate of nodal metastasis. But the significance of our study was less statistically not significant, probably due to the low sample size. And I would like to conclude from the study that the elective radiation to the draining lymph nodes has demonstrated a potential in reducing metastasis. Currently, the data and evidence supporting this practice is limited. However, further randomized controlled trials are indicated to prove this point. The limitations for my study was the small sample size, a low number of patients who received radiations, and a retrospective review, and the non-comparable groups, because lesser number of patients had the irradiations compared to the non-radiated group. And these are the references. And I would like to invite the questions from you guys. Thank you.
Thank you very much for your presentation. So in terms of squamous carcinoma, you mentioned a group T3, T4, is that right?
Yes.
With negative nodes clinically and radiologically. Do you do sentinel lymph node biopsies in these patients? Is there a way to do it? Can you do it?
We didn't do the sentinel lymph node biopsy. We assessed the patient clinically, and then when the scans are available, we saw it in the scans as per the MDT recommendations, because we have quite good interpreters of scans in SKM. So in our MDT, when they look at the scans and they decide upon that, as doing the sentinel biopsy could probably lead to unintended interventions to the patients.
Right. Yeah, because I'm not a plastic surgeon, you know. So what is the standard of care in terms of T3, T4, you know, that you may be comparing with in your study? Do you have a standard of care in the plastic surgery literature that kind of led you to this retrospective review?
Yes, so the T3 and T4 and NOT patients, they are mostly kept on surveillance. This is currently the standard practice. Who doesn't have the lymph node positivity, they are kept on surveillance. But those patients, sometimes certain surgeons prefer radiating the draining lymph nodes after the excision of the primary cancers. So we wanted to look at this practice. This study is basically aimed at bringing this idea forward to the future, the current practicing plastic surgeons, so they could look for their preferences and probably adopt this idea, which could potentially lead to a change in practice in the future.
Okay, were there any selection criteria that led you to subject some of these patients to radiation?
I'm sorry, I didn't get very well.
What were your selection criteria for giving radiation?
As I said earlier, this is basically mostly it was on the basis of the preference of the plastic surgeons or the radiation oncologists. My supervisor could answer this very well.
I just add to that. So it's not the decision of the plastic surgeon. So all these cases are discussed in MDTs, and then the decision is made regarding the whether they would receive radiations or not. So basically, what happens is in T3 and T4 lesions, there is a risk of, literature quotes 20% risk of nodal metastasis. In MDT, some of the radiation oncologists' preference is to irradiate these individuals rather than to keep them on surveillance. So hence the idea of, coming forward and looking into the data.
Okay, so the selection happens in the MDT.
Exactly. And about this sentinel lymph node, because the rate of nodal mets is slightly lower, less than 20%. So we do not routinely do the sentinel lymph node biopsies.
Okay, that's good. Thank you very much.
I think the histological grading should have been included in the study because they highly differentiated as compared to highly undifferentiated are less sensitive to radiation. So if the tumor is graded highly undifferentiated, it will more respond to the radiation.
Yeah, that's right. Thank you. Okay, thank you very much. So the next presentation is by Dr. Ahad Ali Nazir from Rahman Medical College, Peshawar. And it's regarding tailoring treatment, unveiling genetic divergence in colon and rectal adenocarcinomas for precision oncology. Dr. Ahad, please.
Assalamu alaikum everyone. I'm Ahad Ali Nazir, a third year medical student from Rahman Medical College. And today I'll be presenting my research project on the tailoring treatment of by unveiling the genetic divergence in colic and rectal adenocarcinoma patients for precision oncology. As you know, that colorectal cancer is the third most common cancer globally, and the fourth most common cause of cancer death, affecting both genders equally. It often starts asymptomatically, thus leads to a late diagnosis and poor prognosis. The current therapeutic measures for CRC includes FOLFOX and KPOX therapy, but despite of giving such a aggressive therapy, the recurrence rate is still 42% according to literature. So the problem that we identified was there is a lack of targeted therapy that leads to poor prognosis. There is a lack of targeted therapy that leads to high relapse rate and poor prognosis. Our objectives were to explore the genetic diversity among the colic and rectal adenocarcinoma patients and to explore the potential of developing a tailored therapy for them by targeting the genetic drivers of the disease. So before starting the methodology and results, I just want to give an overview of precision medicine. As you know that genes are the software of life, they express in certain ways to produce proteins. But in some cases, if you have a mutated or defective gene, the expression would be differential expression. And as a result, a diseased or malignant protein is produced. What we do in precision medicine, we look for we find the domains that are, we look for the domains of the proteins that are misfolded. We spot the mutations behind them and we target them through some personalized drugs. Thus, it is called tailored therapy. This was a workflow that we followed. Started with the genomic data hunt, followed by data pre-processing and normalization, DG identification, gene ontology, network analysis, and finally drug repurposing. So for genomic data hunt, we went to cBioportal or the cancer bioportal. The total samples included in our study was 4,648 patients with 2,824 colic and 1,824 rectal cancer patients. These are the 14 data sets that are included in our study. The next step was doing the pre-processing and normalization of the extracted data. It was done on different bioconductors on R. The next step was to identify the DEGs. It was done on Lima package by R. So we got total 6,890 differentially expressed genes for colic and 1,302 rectal differentially expressed genes. They were filtered on the basis of their log FC count and adjusted p-values, and we still got highly specific and significant 1,067 genes that were responsible for causing colon and 95 genes that were responsible for causing rectal cancers. As you can see in this enhanced volcano plot, the outliers labeled in red and blue are basically the culprit behind these two conditions. Then these are the top 5 differentially expressed genes with the colon genes on the right table in the right table and rectal in the left, along with their log FC values and adjusted p values. The next step was to do gene ontology. It was done on David, and all the differentially expressed genes were studied on the basis of their cellular component, molecular function, and biological processes. Then we decided to visualize the interaction between those genes. It was done on Cytoscape using string extension, and this is the network for 1,067 colon genes which had 22 nodes, 223 edges, and overall score of 21.238. While this is a network for 95 rectal genes with a node count of 5, edges 9, and overall score of 4.5. Then we decided to do a genetic diversity test. It was done on Veni, and to our surprise, there are only 49 genes similar which are responsible in causing both colon and rectal cancer that further strengthen our strengthen our concept about the genetic diversity or the diversity among the genetic landscape which causes these both conditions. The last step was to do drug repurposing. It was done on the drug gene interaction database, and we got 455 colic and 264 rectal drugs. They were filtered on the basis of their interaction score and FDA approval, and still we got 41 highly specific colic, while 4 drugs for rectal cancers. These are the top drugs of our list. They are sorted on the basis of their interaction score. Colic drugs on right and rectal on the left in the left column. So our study conclude that there's a significant genetic diversity among colon and rectal adenocarcinoma, which challenges the ongoing use of current therapy for both cancers. So a personalized approach should be implemented to improve patient outcomes and reduce the burden of colorectal cancer patients. In future, I want to take this project to wet lab by doing various experimental analysis, by conducting in vitro and in vivo experiments, and to validate the efficacy of my drugs experimentally. So that was all. Thank you so much. If you have any questions.
The difficulty really is, as you mentioned, is to identify the consistent gene that you could map out.
Yes.
And that's been the reason why you have so much variation in drugs, driven by pharma industry, of course. The bit that you want to do next, I'm sure, is already done by the pharma industry, taking it to the animal lab and then doing a phase 3 trial to see what the efficacy levels are. In our setup, let's talk about our setup, because you hopefully going to produce some excellent outcome with this paper and make some recommendations. What genetic mapping tests are available to our patients?
So, sir, even in Peshawar, like I'm from Peshawar, in Rahman Medical Institute, we have a state-of-the-art precision medicine lab that offer a complete gene expression test for the patients of different cancers, including breast cancer, solid tumors, and brain tumors. So, like, it is available in Peshawar. However, it is expensive at the moment. So, in future, maybe we can.
Yeah, you will make it cheap and win the Nobel Prize, I'm sure. Well done.
Thank you so much, sir. Sorry, sir? Yes, sir.
Gradually expecting and then got to data showing the concept of cancer. So those genes have already been studied elsewhere, and you
No, sir. No, yes, sir. So we got the data set. We merged different data sets. As I have mentioned that we had more than 4,000 samples in our study. So more than 14, total 14 studies were merged and they were studied. So the top common genes in those 14 data sets were included. So those these are the common genes in 14 data sets in 4,000 cancer patients. So it is kind of significant. It wasn't documented before. Thank you so much. No.
Having a physical clinic. The rest is missing. So
फातिमा गिलानी का हो गया, नूरुल ऐन का हो गया, सुंबलनाज हो गई है, शादाब हो गई है, मरियम असद हो गई है, अरूब हो गई है, रिमशा हो गई है, खुशबख्त हो गई है, नौमान शुजा वो 10:30 पे था। आहदीन है।
are you sure there's nothing there?
आपके पास presentation नहीं है?
Okay. Thank you very much. It's been an excellent session. Thank you very much all. It's been an excellent session. Excellent participation by the audience. Some very constructive comments made. But all in all, I would have show of hands and the excellent effort put in by the team at Shaukat Khanum. My compliments to all the presenters, their tutors, the surgeons, the consultants, and thank you very much to the participants.
Sure.
I would like to see lots of these presentations turn into published manuscript within a year. You know, we do bit of work. Remember, if you don't publish, you perish. Nobody would believe your figures unless they're out there in your peer review journal. So please, it would be fantastic, hopefully, if we are alive and well in a year's time, to come back and see majority of these abstract resulting into published evidence and you presenting and referencing your own papers. So this is one incentive that you should take away from here. Excellent supervision. Obviously, another thing obviously is that we wanted more data to come nationally rather than just from one institution, which is always a disappointment when I come to these meetings. If you could encourage your colleagues and perhaps sort of, you know, give them the idea and cultivate this culture, it would be nice. Thank you. Thank you.
Thank you very much. I would like to thank all the participants. The talks were excellent. I think a lot of effort goes into each presentation, and it just goes to show, I think we are well on the trajectory to excel in medical practice for the betterment of our patients. Thank you. So we'll conclude this session.
Assalamu alaikum. Welcome to the free paper session. So we have about, I think, 11 or 12 free papers. We will start without much ado. So our first paper is by Dr. Imran Iftikhar. It's real-world outcomes of PET-adapted treatment of classic Hodgkin's lymphoma, a single-center study.
May I start?
Yes.
Okay. Thank you, everyone. My name is Imran Iftikhar, Fellow in Clinical Hematology. Today, I'm going to present real-world outcomes of PET-adapted treatment of classical Hodgkin lymphoma, single tertiary care center study. So, no conflict of interest. And classical Hodgkin lymphoma is the most common and curable form. Its peak incidence in 20 and 70, high curable rate, but the main focus of the treatment to reduce the toxicity and improve the survival outcome. Our one approach is PET-adapted RETHL strategy, which is adopted by multiple centers, including ours. In the next slide, there is a RETHL trial design. All the patients received 2 cycles of ABVD, after that had interim PET, and then PET positive patients switched to escalated BCOP, and PET negative patient further divided into 2 groups. One group received ABVD and other one received AVD. Even though in this data escalated BCOP patient, majority of the patient achieved CMR, although it lacked the randomization, but historical data improves that the escalation has the better outcomes as compared to the continuation of ABVD. In our study, retrospective cohort analysis was done from 2019 to 2021 after the IRB approval. Inclusion criteria include age of all the patient classical Hodgkin lymphoma, 18 years, treated with the PET-adopted approach, exclusion NLPHL, and early stage patient, and who did not have the interim scans and not opt the treatment at the scan. Primary endpoint responses, survival outcome, OS and PFS, and secondary endpoint assess the toxicity and effect of radiotherapy. So the total number of the patient is 169. As you can see in this flow chart, majority of the patient received ABVD. Only 5 patients received BCOP due to the non-availability of docarbazine. After 2 cycles, all the patients underwent the interim scans, IPAT positive patient number 49 and IPAT negative 104. Out of 49 patients, only 17 patients escalated to the escalate BCOPs, and the interim and negative patient, only 20 patients received ABD. Statistical analysis were done by the Kaplan-Meier outcome curves analysis, and univariate and multivariate analysis are done by the SPSS program. So the results, here you can see that median follow-up 3.6. And from this chart, it is easily shown that the majority of the patients were male, and 70% of the patients presented with the B symptoms and were in the stage 3 and 4 with the IPS score of 3 or more. In this, total number of the patient underwent the PET scans, interim scan 169, out of which 16 had the CT and CAP due to the PET machine issues, and 153 had the interim scans. And in the bar chart, you can see that majority of the patient achieved the CMR 67, partial response in 32, and disease progression in 0.6. Here, end of the treatment scan were not done in the 10 patients due to the loss of the follow-up, due to the deaths. And here the overall responses rate, majority of the patient achieved the CMR 75 and partial responses in 6% and disease progression in 13% patient. Here's the survival outcome of whole cohort. This is a Kaplan-Meier curve. On the right side, there is a OS, and on the left side, there is a PFS. And you can see that the 3-year OS in our studies is 91.7 and progression-free survival is 75.8. And survival outcome of whole cohort according to the radiotherapy. XRT given only to the 38% patient.